Now, you mentioned that a common cause of excessive sleepiness is not getting enough sleep at night, but there are other common causes too of relatively common causes of sleepiness, right? Such as
absolutely.
obstructive sleep apnea syndrome, narcolepsy, and we're going to focus on narcolepsy today. So Karen, why don't you tell us a little bit about what is narcolepsy?
Yeah, so narcolepsy is a chronic neurologic condition that causes excessive daytime sleepiness. But it's more than that. It's really a problem of sleep-wake stability. So patients oftentimes have difficulty staying awake during daytime hours, but at night they also have problems kind of consolidating or maintaining sleep. And most specifically, it's a disorder of REM sleep, rapid eye movement sleep. So some of the symptoms, which we'll go over in a second, relate to that inappropriate REM sleep that comes on during daytime periods or during sleep-wake transitions.
And what causes this?
So there's two subtypes of narcolepsy. There's type 1, which is narcolepsy with cataplexy, and type 2, which is narcolepsy without cataplexy. And type 1, the one with cataplexy, we know is related to low hypocretin levels. And hypocretin is a neuropeptide in the brain that helps stabilize these sleep and wake states. So when it's gone, there's sort of this imbalance between sleep and wake and a fluidity between those states. We think that that loss of hypocretin may be related to an autoimmune process because nearly 90%, if not more, patients with type 1 are positive for a specific HLA type DQB10602. Type 2, we really don't know what causes that.
And what may cause this loss of hypocretin and this autoimmune response? Are there any theories about why this comes about?
So we don't have the direct mechanism mapped out, but there is definitely tantalizing evidence. There was a recent study showing that patients with type 1 tended to have these autoreactive T cells, so we think this may be a more T cell mediated process that recognized hypocretin peptides. So we're getting closer to understanding that maybe it may be a disorder of T cell immunopathology rather than, say, autoantibodies.
Okay, and it's been suggested that it may be, in many patients, an infective stimulus that may set this process off.
Yes, and that's been observed based off epidemiologic data showing that there's spikes in incidences with cases of streptococcus, the H1N1 flu, and then with the H1N1 vaccination, a specific type of vaccination called Pandemrix that was used in European countries.
Yeah, that didn't happen in the United States, I understand. There wasn't any vaccine-induced narcolepsy in the United States. And what about the prevalence now? When does the narcolepsy generally start, and what is the prevalence of narcolepsy?
So narcolepsy typically starts somewhere between the first and second decade of life, typically, in most patients. Even when it's diagnosed as adult onset, in retrospect, almost 50% of patients report having some symptoms during childhood. So typically between 10 and 20 is the peak incident, and then there's maybe another peak between 20 and 30 years of age. And the incidence is not clearly known, but somewhere between 0.3 and 0.5 per 100,000 people. So this is a rare disorder. And in children, it's not exactly well known, but maybe up to be 0.8 per 100,000. But of course, there's the delayed diagnosis problem where there may have been pediatric onset, but not diagnosed until adulthood.
So, Lon, when somebody has narcolepsy, how are we going to be able to tell it? What are the main symptoms that patients are going to present with if they have narcolepsy?
So before answering this question, I'd like to just contribute one other point to what Dr. Rosenberg eloquently described, which is the use of the sleep diary or the sleep log. So I would urge all clinicians in all practices that when they see patients who have excessive daytime sleepiness, to provide some measurement of how much sleep, how regular the patient's sleep-wake patterns are. The sleep log or the sleep diary really is the one beautiful test that can tell us, is the patient sleep-deprived? Do they have irregularities in their sleep-wake patterns? And you don't need a sophisticated watch-like device like the accelerometer although having it is an advantage. So this is really a bridge between the patient's symptoms to deciding when the patient should really undergo a more sophisticated sleep test like the PSG and MSLT.
So even if a physician doesn't have a sleep log available to him, I mean, it's most important for every physician, if they're going to be asking somebody about sleepiness, they must understand what that patient's sleep-wake pattern is. And it's not just a matter of asking someone what they usually do, because most patients are going to tell you, well, I go to bed at 11 and I get up at 7 in the morning. And then they neglect to tell you that on the weekends they go to bed at 3 a.m. and you know, sometimes can be in bed till midday or after, or they may cut themselves very short of sleep on the weekends because they're up so late. So understanding that sleep pattern is important.